I intend that my presentation will not be a formal lecture. I will just share with you our understanding of customized biosimilar practice, and I will concentrate on the cons. Nothing? Okay. By the recognition of increase and the prevalence and the incidence of chronic diseases and its comorbidities, and by better understanding of the immune pathophysiology of these nasty diseases, and recognizing that there are certain molecules that they are targeting the pathophysiology or the pathogenesis. So people, the Russian and the biologics is coming in the scene, that it will target this molecules specifically, and with follow-up, we found that this make the major change, that there is a good outcome, there's good prognosis, and so on. But unfortunately, these molecules are a large one, and the production of it is cumbersome and demanding and costly. At the same time, whatever you do, there is still a possibility that at the end, your biologics will not be approved. So the manufacturers, the people with the money, they're looking for a molecule that is smaller, and it does not need this demanding, cumbersome procedures. And it's not necessary to be identical, but it is similar. And usually they concentrate on the fact that this should not be superior, should not be inferior, but should have same efficacy and safety like biosimilars. So the biosimilars come into the scene. But with all of these, they started to notice that the adoption of biosimilars slower than they are expecting, especially in the United States of America compared with that of Europe. And they try to track what is the reason behind it, and they found the main reason is a lack of knowledge and lack of confidence. First of this, the people expecting biosimilars to be like a generics. I wrote in my prescription, for example, Augmentin. Then the patient go to the pharmacy, and the pharmacy doesn't have Augmentin. He will give in Jordan Amoclan. So Amoclan is 80% less costly than the Augmentin, which is the originator. But it is not biosimilar, it is just a copy. So biosimilar will not give you the same cost reduction like a generic. The people who is working in the tenders, they will be recognizing that there is a reduction in the cost by around 30 to 35% when using biosimilars, based on the fact that there is a head-to-head comparative analysis between originators or the reference and biosimilar, and at the same time you are not in need to go to do or repeat all the clinical trials to justify switching, interchangeabilities, and so on, but is not applied for generic. Now, so they try in webinars and seminars, and also in the meeting, to stress on the fact that a biosimilar is a biological product, it is highly similar, and biosimilar has no clinically meaningful difference from the reference product. If you go to the industry standards, you see that 46% of the United States consumers have never heard of biologic medications. And 38% of them, they know whether the prescription is a biologic or a chemical medication. And at the end, that means that they rely on their physicians to guide them through this maze of biopharmaceuticals. So on the front is the physician is on the front, so he should be very well equipped with, for example, the committee that you have. This will help him to go safely in the practice of biosimilar, which is not available in every country. So They go to do a meta-analysis looking for the pharmacist perspective of biosimilars. And in short, these are 22 studies included in the review. 19 were cross-sectional, 3 were qualitative studies. The sample size is 19 to 1,500. It's variable. They found that only 20 to 51 of the pharmacists were comfortable if biosimilars were prescribed for all indications and previously used for original products. And the pharmacist acceptability for switching from originators to a biosimilar also varied with a range of 25 to 85. So they don't have the same perspective. They don't have the same knowledge. They don't have the same confidence too. That is usually what we use to see and the real practice. And also, however, most of the pharmacists viewed the substitution of the originator with a biosimilar without the physician permission as unacceptable. This is because everyone is working when this circle needs to be safe and will be supported by the committee, supported by the knowledge, supported whatever. And data from 3 studies reported that you see the variability, how varies is the result. That is 22.74% of the pharmacists had attended biosimilar training. If you take the 22, for example, in one institute, this means that 85% they don't hear about biosimilars, and they practice it in the pharmacy. If we are lucky that 75%, still there are 25% that they don't know what biosimilar is. They obtained information about biosimilars from, this is good, scientific publications and companies and continuing education. Also, in conclusion, that pharmacist knowledge and perception about biosimilars varied, were limited, especially about interchangeability. This is the miss here, interchangeability and switching. That's a miss, really. And substitution, efficacy, safety, and indication. Here to make it more bright, that if you are going to speak about safety and efficacy, I think it is well established. It is well established. You are in a safety zone, but it is the regulation. How to practice, that's the problem. This is the cons. At least this is what I understand. A better understanding of biosimilar amongst pharmacists could help them to encourage the prescribers' acceptance of biosimilars. If we look at the physician's perspective, the data of these 23 studies were extracted. Again, you have 50% to 75% were familiar with biosimilar, while 2% to 25% did not know what biosimilars. Maybe this is a bit surprising, but this is real. This is seen in the real world practice. That is. And at the same time, if you look at, there is around 55 to 95 were confident prescribing biosimilars. This means that there is around 40%, maybe to 5%, they are still not confident too. And 65% to 67% had concern regarding these medications. He prescribed it, but he feels that he is unsafe. He don't know what's going on. That is not because the biosimilars is bad. That's because he is not well equipped with enough knowledge. This is present in the real world practice. Maybe certain countries, certain hospitals, institutes that are lucky that they don't have or they don't suffer from this problem, but it is present. Physicians seem to prefer originators, products to biosimilar, and prescribe biosimilar mainly for biologic naive patients. You know what is the most important factor that urge physicians, at least in a certain institute, to prescribe biosimilar? That is the stakeholder said that, okay, this is a declaration that we will stop using adalimumab, okay? So try to contact your patients, the pharmacists, and tell them that is the biosimilar is quite effective, safe, and I cannot compensate you with the originator. So you have two. He is not concerned about the patients that are already stable in your biologics. That's the real things. And they consider cost saving and the lower price, as my colleagues mentioned. That is one of the main factors. Now, 65 to 95 physicians had negative perceptions of pharmacist-led substitution of biologic medicine. Physicians believe that pharmacists should not practice automatic switching. Hopefully. But the pharmacist in a certain institution does not have except the biosimilars. So you write infliximab, we give you remsima. You write infliximab, we give you Inflectra. That's because he just only have, and me and him, he's having just only the concept that is based on head-to-head comparative analysis. It is safe, it is, and so he does not know in the long term what's going on. He does not know what is the status of the patient. Okay, I will make it short. I will give you just a scenario. That has happened with me. That's happened with at least doctors in Jordan. You have a patient that he is having rheumatoid arthritis, and you prescribe for him, for example, originator A, okay? And by a time, the stakeholders or the administrative say that you don't have it, so you have to switch. Okay, the concept is clear, I switch. Now what's going, you have two arms. If you are lucky, things will go without seeing, and he's happy. If you are unlucky, that the patient either deteriorate or the drug is ineffective, or so is not controlled, there's no more control. So the question, is it the nature of the disease, or it is because of this drug? Based on the fact, which is maybe is not that is objectively documented, which is the immunogenicity. Maybe in your institute you can do it, the antibodies, but maybe in other institutes, is it just only research-based, okay? That is the story. Now you switch to this biosimilars, okay? Now, this happened, that you will see that you are speaking about adalimumab. Now, adalimumab, you have 3 biosimilars now, isn't it? Maybe you have 3 biosimilars of adalimumab. At least 3. This is what I know. So you go for adalimumab biosimilar 1. And then he mentioned to you, okay, by the tender that adalimumab, I was speaking about real practice. He told you that it is not available. We go for adalimumab biosimilar 2. So this raised what we called switching between or interchangeability between biosimilar to biosimilar. Now we're speaking about a new era. There is no any research that support interchangeability, at least to my knowledge, that will support the interchangeability between 2 biosimilars, okay? That's very important. And at the same time, what happened that you go to write a prescription. Here is no problem. 1 minute. لا خلصت أنا. أوكي هذا برجع قاعد أنا. Okay, this is the nomenclatures. You see, you should write the prescription unless it is something else. That is, you should write adalimumab biosimilar between 2 brackets. You see, this is adalimumab biosimilar. And you should write what we call just a batch number, and you send it to the pharmacist. Then the pharmacist should read it, and he should know that you are speaking about biosimilar. If he has it, he should give it. If he does not have it, he should call you back. But it's not always happen, okay? That's one. The second is extrapolation. Extrapolation, what is it? When they develop biologics, for example, for RA, because RA and ankylosing spondylitis do have the same pathogenesis, extrapolation goes easily. But when they go to extrapolate to inflammatory bowel disease, the pathogenesis a bit is different. So they did the clinical trial to that. Now, when it comes to biosimilar, they said that it is identical. It is highly similar, or similar. It is not necessarily highly identical, but is proven to be like a same of the bio. So I will not do a clinical trials. This will reduce the cost, but at the long term, is this feasible? Is this without any complications and so on? You have to wait. This usually make the physician less confident, especially if you are treating a controlled severe panuveitis with infliximab. Until now, I'm very hesitant to shift patient from infliximab to Inflectra or to Remsima, okay? But the naive patient, yes, I will do, okay? Now, the third thing, the last thing, sorry, is interchangeability. When I say interchangeability, my understanding goes into two things. Interchangeability, that I can use it forth and back. Originator, biosimilar. Biosimilar, originator. This is not without risk. And interchangeability give a permission or make it permissible for the pharmacist to do automatic substitution. Automatic substitution will affect your traceability later on and looking for adverse effects. You don't know which one is the reason behind it. I will stop here saying bio thanks, okay?